if you could design a calculator. So with your experience, you talked about the risk stratification. So that's just the path, right? Recurrence. It doesn't give timelines. Like you said, some patients are going to recur 13 years later. We've all seen that. Or a patient who started with low-grade disease, some of them are going to develop a high-grade disease, small number, but it does happen. And sometimes it happens a lot later in their disease course. What do you think would be most useful in predicting that risk? So of course we know certain things, CIS, T1, right? Some of these very, very specific things are going to change categories, but
it'd be really nice to know upfront which patient is going to ultimately not respond to intravesical therapy. So Lars Driscott had a nice paper where he looked at some mutations of tumors in CIS patients, and he was able to predict those patients that were not going to respond to intravesical therapy by looking at a bunch of specimens from patients pre-TUR and then knowing their long-term history. And I think with ctDNA, I think we might be getting closer to that kind of prediction where we could tell a patient right off the bat, okay, you will do well with intravesical therapy and we should continue doing sort of our standard of care, or telling someone, look, you've got an aggressive tumor, a high potential for it progressing, like we do with T1, disease when it initially presents. And so you may want to consider early cystectomy or early trimodal therapy, although the problem is we don't really have good data in trimodal. We have some data for T1 disease, and but not really for papillary. So I think I would say I would want some sort of prediction for who to give intravesical therapy for and who would do cystectomy on.
Yeah, absolutely. I mean, I think when you look at our current prediction tools, what's still in the calculators hasn't changed, right? Since, I don't know when, the 80s probably. It's truly still like stage grade. I think the European risk groups have age, some of those things, but it's still really blunt factors. And I think we're really moving into the next era where we're going to have molecular tests and we're going to have actual tumor specific information that is a lot more than just stage and grade. I think that'll be the next step, no question. We were talking some about AI and the role of, Valor to be able to give us some of those predictive tools. And that's in its, I think, very nascent stages right now. But there is, obviously really provocative data. And I think that those things will start being incorporated into actual calculators.
So just to elaborate on that a little bit, when you say Valor, you're talking about the Vesta-Chai biomarker for BCG versus Gem Doce for treatment decisions.
Right.
Or are you talking about their little printouts, like the graph they give you for recurrence risks, or both?
I guess I'm talking about their, whether or not you're going to be BCG responsive, essentially, because that, I think, is the news we can use, right? That'll help us really get to the point where we're actually providing individualized, like patient-specific therapy, which, again, now we are starting to have more tools.
So I know, obviously, this is something that some of us are using in clinic. I personally am using it, but are you guys? And are you using it to see it, or are you using it to guide your treatment decision?
Yeah, I mean, I wanted to ask you both a question because I'm not exactly sure how to use it. I've been ordering on a few patients. I'll give you a quick anecdote. I ordered it on a patient. And again, with the BCG shortage, I also feel like, especially with the bridge trial almost being accrued, and we might know the results in some time, but maybe from our personal experience, we may, I personally at least think Gem Doce is probably, not inferior to BCG. Of course, we have to wait for the results of the trial. But we used a lot of Gem Doce during COVID when we had no BCG, and we had similar outcomes. So when I order this test on a patient, it shows maybe a decreased, response rate to BCG. It doesn't decrease significantly, but decreased a little bit. So I told this patient, again, in the shortage of BCG, I said, well, we could just go with Gem Doce. They saw another colleague in town at another institution who said, well, BCG is the, gold standard, and you should start with that until we know the results of the bridge trial. And again, I can't disagree with that statement. So I'm not sure, how to use a test. So I'm curious whether either of you would give Gem Doce, knowing if you use that predictive biomarker, would you decide which intravesical therapy to give?
I don't have enough experience at this point. I haven't, we just have sort of incorporated the ability to send a veiler at our institution. I have yet to send one. So this is all within the last 2 months, 3 months maybe. So I can't say sort of from my own confidence. I agree, though, that as a treating clinician, I have just as much faith in Gem Doce as I do in BCG to treat patients. The problem, has always been, again, we don't know which patients, so some are going to do great with one or the other, maybe both, who knows. So at this point, I can't say I would, but I think it's something that is, as a treating physician, like the next thing on my horizon that I really feel like I could do to take the next step for the patient.
So I think one thing to consider is a lot of patients who you send it on are going to come back biomarker absent, right?
Sure.
It's going to say dealer's choice.
Yeah.
And so in those cases, I will just do what I'm going to do. And I think whenever we have a BCG shortage, whenever we're, at least in my institution, doing like half-dose BCG or anything like that, I will often favor Gem Doce, because when we think of BCG being the gold standard, we're talking about full strength, 6 doses, kind of traditional. So if I'm ever in that scenario, then even I feel pretty good about it and I explain it to the patients. This is why, this is what I think. I'd love to see more data. I'd love to see the biomarker in the bridge trial and looking at that. I think that's where we're gonna be. We're gonna have that data. But right now, I still believe in ordering the test. I believe in gathering that data to see how we can best use it.
Yeah, and I think like any new tool that is like a completely new data. I mean, you can look at data, but every clinician's going to need to see sort of their standard data and this next to each other, so you develop faith in that. Because I think that's the only way you can really counsel patients and say, this has been my experience with this, which is why they are coming to you.
Yeah.